safer. It's got multiple other benefits and I believe few, if any, downsides. So what guidelines are now recommending the use of video laryngoscopy for all intubations? Well, it's progressed over the last decade and a significant number of guidelines, the Canadian, the Puma esophageal intubation guidelines, the DAS cervical spine guidelines, some guidelines we're going to go on to, and neonatal guidelines are now recommending using it routinely. People are in a relatively short period of time, people are not going to get away with not using them. We'll talk about one video laryngoscopy study from New England Journal of Medicine, which is the biggest study of video laryngoscopy on ITU, and I'm going to talk through this reasonably quickly. So this was a study of video laryngoscopy, any video laryngoscope they could use against any direct laryngoscope. It was in largely not obese patients, mostly in the emergency department rather than intensive care. The patients were not desperately sick, and most of them were intubated for altered mental status, which is often the case in American studies, rather than acute respiratory failure. If we think about that INTUBE study, it was 55% were acute respiratory failure, which is more typical of international ITUs, whereas because there's a profusion of ITU beds in the States, I think people are intubated for lower risk complications, lower risk settings. And most of the patients were not anticipated to be difficult. So only a small number anticipated difficult, and in reality, very few were difficult. They were mostly treated by emergency physicians and mostly by residents, which again, I think is typical of real life. Most of them had, in their training, had done either predominantly trained on video laryngoscopy. So this was unusual in that it was a group that predominantly, their prior experience prior to the study was predominantly of video laryngoscopy. And most of the intubations, in fact, were straightforward in terms of laryngeal view. So 7% difficult, well, 20% difficult in the direct laryngoscopy view, and 3% in the video laryngoscopy. I mean, perhaps we shouldn't go further. That's fairly obvious. So their primary outcome was first pass success. I frankly don't care about first pass success, to be honest. It is important that we get things right first time, but as an outcome for a study, it's not a very patient-centered outcome. The study was stopped after because it was showing that video laryngoscopy was too effective, but there was no difference in rates of complications. And if you looked at any subgroups, they did sensitivity analysis, looked at any subgroups. Again, everything favours video laryngoscopy. It's all over on the right, favouring video laryngoscopy. This is the time along the bottom, and so if you're below here, you remain unintubated. If you're up here, you've been intubated. So at 60 seconds, or let's say 100 seconds, you either had completed your intubation or you hadn't. But there was a 15% difference in the rate of success of intubation, a massive difference. And if you then factored into that the operator's experience in overall intubations, then that difference was maintained, and it's only when you reached up here that the two curves tend to approach each other, but there's still a benefit of video laryngoscopy. So if you've previously done a couple of hundred intubations, then your likelihood, so particularly novices benefit, but the very experienced probably get less benefit from video laryngoscopy. But most people will get benefit from video laryngoscopy, however many they've done. So let's skip through those actually. So here's a quite interesting but slightly complicated chart. It shows essentially, it shows how often, how many intubations have been done in the past, the proportion that were done with video laryngoscopy. And it's a heat map. So the darker orange it is, the more likely video laryngoscopy is going to be beneficial. And so if you've not done many and you're mainly and you haven't done video laryngoscopy, you benefit vastly from video laryngoscopy. The only group down here, this tiny little section where direct laryngoscopy is favoured, is those patients who've done 250 at least intubations in the past, almost none of which were with video laryngoscopy. And those people probably haven't learnt to do video laryngoscopy adequately, I suspect. But even if you have done lots of video laryngoscopy, still video laryngoscopy favours you. Some people have used this chart to say that experienced people don't need to use video laryngoscopy. For me, that is bunkum. I'm going to jump through that, and then the last section. I'm just going to jump through what where we are with the national recommendations. So the first set of guidelines in the UK for tracheal intubation were written in 2018, and they emphasised, they built on the Difficult Airway Society guidelines, which have the principles of an ABCD approach to managing the difficult airway, a very linear approach, optimising your first attempt at intubation. If you fail with that, rescuing the airway with a supraglottic airway and thinking about what you're going to do. If that fails, attempting face mask ventilation, and if that also fails, moving then on to opening the front of the neck with 3 attempts at each of those procedures at the time. And the Difficult Airway Society guidelines, which were also with ICS and FICM, emphasise the otherness of the critically ill intubation, how very different it is from the routine anaesthesia intubation. It was big on human factors, the intubation team, and it emphasised checklists for the first time, emphasised video laryngoscopy over direct laryngoscopy more than the previous DAS guidelines, having too many attempts at anything, the emphasis on capnography to confirm intubation, and cycling through face mask and supraglottic airways rescue devices. So here is the first guideline to suggest how many people and how they should be organised to undertake intubation. And then we wrote about a 6-member, 5-member or 4-member intubation, with 4 members being the minimum that we wrote about at that time. Here was a checklist. This actually originally came from the Southwest, from a group of anaesthetists and intensivists, and with Carol Peden in about 2015, and we co-opted into NAP4 and then into this study. And here we have where you have this ABCD approach. In the middle, you have cycling between face mask ventilation and a 2nd-generation supraglottic airway device as a way of rescuing the airway when you run into difficulty. And if you succeed with either of those, you stop and you use your common sense and your pause to decide what is the best thing to do for the patient at that time. Not all patients will be able to wake up or wait for an expert. And here's the sort of expert sidebar here for further intubation attempts if necessary. In 2020, there was a need for a difficult guideline specific to COVID. The only things that they brought in that were new was bringing in the hip dump and updating that checklist to emphasize the pre-intubation preparation for safety of staff, and after leaving the same thing, but the same preparing the patient, undertaking the procedure and post-procedure checks. And we came up with this sort of SAS, safe, accurate and swift. And though that was supposed to be specific for COVID, safe for the staff and patient, accurate, avoiding unreliable, unfamiliar or repeated techniques, and swift, timely, without rush or delay. I think that's actually quite a good thing to remember about tracheal intubation. And I'm not going to de-emphasize COVID. It's still around. It's really important that we remember that it's airborne. Healthcare staff are particularly high risk of getting recurrent infections, and that is associated with long COVID. And the hospitals are a melting pot for COVID transmission. Healthcare staff generally have at least 3-fold higher rate of COVID infection than do the community they live in. Most of the hospital IPC guidelines are wrong. And while intubation, mask ventilation, suction, placing a supraglottic airway, suctioning through a supraglottic airway are not aerosol generating procedures, the sick, coughing, tachypneic patient is an aerosol generating patient or person. And so we should be taking care. FFP3 masks do work. CPR, which remember happens in 3% of our intubations, is a very potent AGP, probably the most potent AGP that has been studied. So we should respect COVID, and I would entreat you to wear an FFP mask and consider a visor for intubation. The last guideline I'm going to talk about, just so it's mentioned briefly, is the Preventing Esophageal Intubation Guideline, which is endorsed by international guidelines multiply, including the Association of Anaesthetists, the Royal College of Anaesthetists, Intensive Care Society. So this is de facto a UK national guideline. It emphasises using a video laryngoscope. Look at the view you get on the right compared to the view you get on the left. Where are these tubes? Well, they're all taken with video laryngoscopes. They're optimal views. These are all these tubes are in the esophagus. Could you tell that? It emphasizes the need to have end-tidal CO2 monitoring and pulse oximetry for every single intubation. And that really should be capnography. I'm not really interested in these litmus paper tests, which unfortunately the neonatologists still persist with. But we should have end-tidal CO2 for every single intubation. It's perfectly achievable. There was a slogan from the Royal College of Anaesthetists which said "no trace, wrong place," which was designed to emphasize that capnography is still present if the tube, if the tube is in the if the tube is in the correct place in cardiac arrest. But actually, there are quite a lot of dodgy traces, not flat traces, that are associated with esophageal intubation. So this guideline moves on to sustained exhaled capnography. So that's a CO2 trace which rises and falls with expiration and inspiration, is consistent or increasing in amplitude, has an amplitude of more than a kilopascal, and that's pertinent to cardiac arrests and is clinically appropriate. So these three, the normal capnograph, the rising capnograph, or an attenuated trace which is appropriate to clinical context, perhaps a pediatric tube with a large leak, are appropriate, whereas anything that looks different like that, descending or erratic, is not. The second point of the guidelines, or the third point, is don't use clinical signs to exclude esophageal intubation. They're unreliable, and there's now good evidence to support that. So capnography is the only thing you should use. And then there's some really sort of fairly soft stuff in the guideline. The intubator should explain what they're seeing. If they're using direct laryngoscopy, which I wish they wouldn't be, they should say what they're seeing. I've seen the full view of the tube going through the cords. But if there are two of you and you're using video laryngoscopy, then the co-intubator, the assistant, whether that's the another intensivist or whether it's the assistant, should say what's going on. And both people should confirm they have sustained capnography and that saturations are stable. So I've seen the tube go through the cord. I've also seen the tube go through the cord. We have sustained capnography. We have a correct waveform, blah, blah, blah. Nurses, physiotherapists, everybody should understand capnography. I'm going to talk about this afterwards. If you don't understand capnography, it takes 5 minutes to learn it. If there is a dodgy tube or there's desaturation, the tube, if there's a dodgy trace or concerns about esophageal intubation, particularly if there's desaturation, the default response should be to remove the tube. And this accepts that some tubes placed in the correct place will be removed. Revert to face mask ventilation or supraglottic airway and be prepared to be wrong. Fiona Kelly, adhering to that mantra, has saved a life, I believe, in our theatres, doing that correctly. If you can't, because it's unsafe, take the laryngoscope out, there are 3 ways to confirm that the tube is in the right place. That's in addition to repeat laryngoscopy, bronchoscopy, ultrasound, esophageal detector devices. So that's the algorithm that goes with that guideline. And finally, the guidelines specifically say that there should be interprofessional educational programs to address technical and team aspects of this team performance. And here we've got pictures of our regular airway teaching going on, which includes the ODPs, sometimes the NT, anaesthesia, ITU, medical directors, etc., etc. It's brilliant to do it. And I'm going to stop there in case there's time for 5 minutes of questions, I think, maybe less than that. Okay.
Brilliant, Tim. Thank you very much. That was a really huge amount of data summarised very succinctly and very clearly. So thank you very, very much for taking the time and the effort to do that. I'm going to open the floor to questions or comments. So questions, comments or thoughts, please. So whilst people are just thinking, I'll come to you in 2 seconds, Charlie. So a lot of people on the call will know that as a network, we do peer reviews for every hospital or every unit, I should say, in the Southwest, formally every 2 years and informally every other year. And you'll all be delighted to know that whether or not a video laryngoscope is immediately available and is your first pass your first choice of intubation device always forms part of the review. And for those units who don't do it or aren't there yet, that always forms a line in the recommendations which prompts the execs to support the unit to buy video laryngoscopes where necessary, and should hopefully prompt departments to consider their practice. Charlie.
It relates to that, Andy. So in Bath, you say that all intubations are with a video laryngoscope. We've got a problem that the further you are from anaesthesia and ICU, the less likely you are to have a video laryngoscope. So, you know, CT scanner, cath lab. So how do you ensure that you always do have that?
Perseverance, actually. So we did a survey in about 2015, Fiona and I and a couple of others, and we found exactly that as you got more likely to be in a location where airway problems were going to occur, the less likely you were to have a video laryngoscope nationally. It's not really acceptable. There are guidelines and recommendations, so it includes in NAPS, you know, so NAP 4, in NAP 7, those guidelines that I've just gone through. So there are numerous guidelines that now recommend that you should be using video laryngoscopy for all intubation. So for every intubation that you don't want to accidentally intubate the esophagus and not recognise it, you should use capnography, oximetry, and video laryngoscope. That's now a national guideline. So the PUMA guidelines, which are now endorsed by the college, or supported by the college, endorsed by the association, and supported by ICS. Those now state that. That's fairly robust. I think if you run into a major problem and you haven't used a video laryngoscope, at some point someone is going to come on the wrong side of the law, unfortunately. And I don't support that. I don't want that to happen, but I think it is inevitable. Guidelines are used in coroners' courts and in more confrontational courts of law as default for good practice. It costs money. We had a business case. We had 50 versions of the business case, and it took us 5 years to get our business case through. What Fiona Kelly advocates is that you try and increase the amount. So try and go to default, you know, first up video laryngoscopy in a set of theatres, and try and collect some data or opinions on whether that's deemed to improve safety, because hospitals like local data. So you can then combine that with national data or published data of efficacy plus national guidelines, and take that to your department, to your trust, and plead for the money to achieve what is an increasing standard of care. It's difficult, it's not straightforward. If you do create a business case, the most important thing to do with that business case is to insist that you go to the meeting where they make any decisions and take with you a mannequin head, a direct laryngoscope, and a video laryngoscope. And nobody who isn't medically trained, who sees you using the two and trying to intubate an awkward mannequin, will be in any doubt as to which is the safest.
And do you use, just a final question, do you use like glide scopes in your kind of emergency bags? Do you carry them around? Or
yeah, so we've got in our so if we go to cardiac arrest, we use iGels. So the default is that patients are not intubated on the wards. So ED, ITU, anaesthesia has got CMAX, but we also have some CMAX which are grab and go, so that if somebody does need to be intubated on the ward, we can get them to the ward very quickly. They were in the grab. There were some very portable ones in the grab bags, but I think we've now defaulted to just have the iGels. And there is a direct. We do have a direct laryngoscope. The irony is that we have a direct laryngoscope in the bags, a cheap throwaway one, but we prefer to use video laryngoscopy. And we've had a persistent problem with the direct laryngoscopes not working.
Thanks.
Because they're cheap and they're cheap and cheerful, and they have a significant failure rate. Video laryngoscope don't. And I would emphasize that if you're going to get video laryngoscope, please try and get a reusable one. It's better for sustainability, but most important, they work a damn sight better. They are not big and clunky and so the single-use ones, because they're plastic, often have a big, large dimensions and are actually more difficult to use. Also, if you don't have a shared screen, you don't get the human factors benefit. So you want to use something that's got a separate screen, a big screen that everyone can see, not just you. Look at the little screen here, and you want to get something that's reusable. It costs money. It needs a business case. It's not straightforward.
Thanks, Tim. So, Charlie, I think you're probably getting the idea that Tim was instrumental in getting Bath set up the way it is at the moment, along with Fiona. So just to add one final thing to what Tim said there, the departments have got CMAC on a stand with a screen, as Tim describes. But if you need to go to the cath lab or the ward or whatever, we've got portable CMAC. So there is just a portable screen that clicks onto the top of the blade, and you can take that out and about if you need. And we have that on our sort of emergency outreach intubation trolley. So there is still the option of using video laryngoscopes if you're out and about, as well as just in a particular department. Thanks for that question. It's a good point. Okay, any other thoughts, comments, or questions for Tim? Brill. Tim, thanks again very much indeed. Lots and lots of important evidence summarised very succinctly and very clearly. Thank you very much for your time.
Pleasure.
Really grateful.
Cheers, everyone.
Okay, and with that, I think we've come to the end of the session. So if anyone's got any other final comments or queries, I'll just pause for a moment. We'll be really pleased to have any feedback from you about how today was and whether or not we should do it again, or whether we should change what we do in any way. If you could drop Sarah Millett a line. Sarah, I wonder if you could put your email in the chat. Then we'll have a look at those in due course. But pending that, just really grateful for your attendance. Thank you very much. Have a good evening. Thanks, Sarah.
Thank you. See you soon.